Hey, all, welcome back to the Real Life Pharmacology podcast. I am your host, Eric Christensen, and today I'm going to cover testosterone. So, testosterone is a medication used primarily in the setting of hypogonadism. So, essentially, this is replacement where patients are deficient in testosterone. Now, from a mechanistic, physiological standpoint, testosterone and its derivatives are found in the body. They're classified as an androgen. And androgens are really responsible for creating, maintaining male characteristics and the development of male sex organs. Now, you've probably heard about steroids primarily through abuse if you follow sports, athletics, track and field, baseball, you name the sport, and testosterone has probably been associated with it as a potential drug to be diverted. And in addition to, those male characteristics and formation of those male sex organs, anabolic steroids, like testosterone, promote muscle building. So you can imagine, regardless of your sport, if you're bigger, faster, stronger, there's potential for abuse of these agents. So definitely keep that in mind with testosterone for sure. Now, one really unique thing about testosterone and the commercially available products of testosterone is there are a ton of different drug formulations. We've got intramuscular, we've got topical testosterone like gels and patches, oral, injectable, as far as we've got subcutaneous pellets, for example, that are kind of timed release, delayed release of testosterone. So multiple different avenues to deliver testosterone in those patients that need it. One really important, what I think is an important patient education point, particularly with topical agents, especially topical agents that have strong systemic absorption, is that risk of incidental exposure to others that may be, helping pick up medications or, closely intimate with those that are using these medications and they're on the skin. And probably most concerning with testosterone is it does have some negative impacts if a patient, a female, is pregnant and they're exposed to that. So be really, really careful in educating patients that may be using the topical gel or the patches, that, skin-to-skin contact with that gel or, coming in contact with that patch, that drug is obviously going to be absorbed through the skin. That's how we're using it. And in pregnancy, we can have some really negative outcomes there. So be extremely careful with patients. Be sure to educate them about those risks, especially for those topical agents. Now, adverse drug reactions from testosterone. So you can probably think of some of the things that maybe you've heard associated with the abuse of steroids or androgenic anabolic steroids. So I think of acne. You've also heard the term, roid rage. So you can have some emotional changes, more aggressive, agitated, anxiety, insomnia. Things like that can happen from excessive doses of testosterone, and certainly in situations of abuse where people are abusing these for their muscle building purposes. But in addition to that, you might say, well, why don't we use testosterone a little bit more often? Well, there is more risks than just superficial risk. And testosterone can raise blood pressure. And with that, there's definitely associations with cardiovascular risks. So things like heart attacks, strokes, Testosterone can also increase lipids. So again, there we're creating, maybe exacerbating multiple risk factors that could increase the risk of cardiovascular events. In addition, there's association with DVT and PE risks as well there. So lots of potential negatives from the use of testosterone, so we need to be really careful. Need to be paying attention to the patient population that we might be using this medication in as well. So let's take a quick break from our sponsor and we'll finish up on drug interactions. If you're in the market for board certification study material, if you're a pharmacist, pharmacy student, go check out all our resources, meded101.com/store, S-T-O-R-E. In addition to all those exam resources, we've got clinical books, clinical education. We've got Audible Books as well. Promotion we have going on. You can get your first Audible book for free. So if you've never listened to an Audible book, go check out Pharmacotherapy or Thrill of the Case. Both are excellent clinical pharmacy resources where I've shared a lot of my case studies and clinical pearls, things that you actually see in clinical practice. So great way to get a little bit of experience without actually being in practice. So definitely go take a look at those resources, support our sponsor, meded101.com, and support this podcast, Real Life Pharmacology, as well. Again, check all those out, meded101.com/store, S-T-O-R-E. So let's finish up on drug interactions. With testosterone, there isn't a ton of clinically significant drug interactions that you need to be aware of, but I'll highlight a few here. So one is warfarin. It can increase concentrations, or there is that potential to raise those warfarin concentrations, which could increase INR there. So in a patient that you're starting testosterone, you're probably going to want to check an INR. And they're on warfarin, you're probably going to want to check an INR, within maybe a week of starting that testosterone. Also educate your patients, be aware, hey, you're at increased risk of bleed, bruise, keep tabs on that, and definitely let us know if you're having any troubles or concerns in that department. Now, corticosteroids, when we say steroids in clinical, in healthcare terms, we generally think of corticosteroids. So for an asthma exacerbation, for a rheumatoid arthritis flare, when we hear steroids, we generally think of, we're talking about corticosteroids to reduce inflammation. When we say steroids to the lay public, you may get different results. There may be patients that have been on corticosteroids in the past for inflammation, and they may recognize that that's what we're talking about. But many patients that haven't been on steroids, they associate steroids with testosterone and drugs of abuse there. There is a potential interaction between the two, and it's more of an additive type effect, particularly with the risk of fluid retention and edema. So if you're using them in combination with one another, there may be some additive effects there to keep an eye out for. And then we do have some alterations in kind of glucose metabolism and things of that nature. So patients who have diabetes and are taking agents that either are insulin or stimulate the release of insulin in the body, we can run into some risks of hypoglycemia. So pay attention in a patient that, maybe they're on glipizide, maybe they're on, a long-acting insulin like Glargine. Keep an eye on those patients, maybe a little bit closer when we first start that testosterone, because you may see a little bit of a drop in blood sugar and potentiate that risk for hypoglycemia. So I think that's going to wrap it up for today. If you enjoyed the podcast, if you found it helpful, do us a huge favor. Leave us a kind rating review on iTunes or wherever you're listening. So appreciative of all that have done that. Also, go to reallifepharmacology.com, snag your free 31-page PDF simply for subscribing to follow the blog or the podcast when we've got new releases and new episodes ready for release. So once you sign up, you'll get that free PDF, 31 pages of the top 200 drugs. And I highlight really important clinical things that actually happen in real life with those top 200 drugs. So go check that out. Again, totally free resource just for following the Real Life Pharmacology podcast. So I'm going to wrap it up for today. Thanks so much to all of you who have supported our sponsor, meded101.com. If you haven't done so yet, again, go check out those resources there, meded101.com/store, S-T-O-R-E. And thank you so much for listening. Take care and have a great rest of your day.